Hello, my name is Perina Zambrano. I am a student of medicine and I am going to expose you about Emapalumab in children with primary hemophagocytitis lymphohistiocytosis. Definition: primary hemophagocytitis lymphohistiocytosis is a rare syndrome characterized by immune dysregulation and hyperinflammation. It typically manifests in infancy and it is associated with high mortality. Application in med. Emapalumab is a human monoclonal antibody to interferon gamma which stimulates its binding to cell surface receptors and activation of inflammatory signals. Emapalumab is used to treat the severe inflammatory condition of hemophagocytitis lymphohistiocytosis. Pros and cons. Emapalumab is used to treat the severe inflammatory condition of hemophagocytitis lymphohistiocytosis in which serum gamma interferon levels are elevated. Cons is that some side effects of the drug are constipation, fever, irregular heartbeats, muscle cramps, numbness of the limbs.
To talk to you about targeting cytokines. And if you talk about SGIA, you have heard a lot about targeting IL-1 and IL-6. And the first things I want to simply say is that you actually do not eliminate completely the risk of MAS, even in patients in which IL-1 and IL-6 are inhibited. This is the rate of probable or definitive MAS adjudicated events in the two development program of canakinumab tocilizumab. And you see that the incidence rate is still pretty evident there. What about IL-1 inhibitions? There is evidence of efficacy of anakinra in at least some cases of patients with MAS. You have to use high dose. There is some evidence of resolution of MAS on high dose canakinumab, but there is also the opposite. Case reports of MAS reported as triggered, dotted and question marked by anakinra. I think this is simply patients that were treated with anakinra that develop MAS because the disease was not sufficiently controlled. I don't think that anakinra can trigger MAS. Certainly. And the same is somehow true with IL-6. There are some responses of good response, and certainly the cytokine storm that follows belimumab treatment or CAR T cell therapy is known to respond satisfactorily in several patients to tocilizumab, to IL-6 inhibition. Nevertheless, from what Alexi told you, it's pretty clear that two targets are becoming targetable in MAS and in general in HLH, one being IL-18. Now, IL-18 is produced by a number of cell types, not only in the immune system. It's produced through an inflammasome, essentially through caspase 1, which cleave an immature precursor, pro-IL-1 beta, into a mature secretable interleukin 18, who is secreted outside of the cell. Now, there are two peculiarities about IL-18. One that was mentioned by Alexi, there is an inhibitor, actually it was mentioned by Bas. There is an inhibitor of IL-18, which is a natural inhibitor, is an IL-18 binding protein, binds IL-18, and IL-18 bound to IL-18 binding protein does not bind the receptor. So this is a natural inhibitor. The second peculiar feature, general feature of IL-18, and that IL-18 does very little by itself. It is a cofactor for a number of activities in the immune system and outside of the immune system, not listed here, in the presence of other cytokines. The reason listed here, the reason being that the beta chain of the receptor is not usually expressed, but is inducible by the following cytokines that you actually find listed here as cofactor of the effect of interleukin 18. Now, interleukin 18 is targetable, yes it is, using IL-18 binding protein, which which is becoming a drug. It's called tadekinig, or IL-18 BPs, and has been used in this study to treat adult onset Still's disease, with the idea outlined with the rationale of the high levels of interleukin 18 being present in patients with SJIA and Still's disease. And although the primary outcome of this phase 2 study was improvement of joint count by only 20% and a CRP reduction by more than 70%. Only 40% of the patients, 40 to 50% of the patients achieved this primary outcome. This is not what we are used to see with IL-1 or IL-6 inhibition in SJIA or in Still's disease, therefore suggesting that indeed the target is not chronic inflammation. The target is interfering with MAS or HLH. And this is data from a paper that I believe this data was shown to you by Scott Canna earlier today, showing that IL-18 levels are particularly increased in patients with MAS, in a number of patients with secondary infection-associated HLH, but not particularly increased in patients with primary familial HLH. And indeed, interleukin 18 appear to predispose to HLH. This is pretty clear in mice. This is IL-18 transgenic mice that have very high level of total IL-6, IL-18. They have a free IL-18 not bound to IL-18 binding protein. They're fine unless they're triggered with an innate immune stimuli like toll-like receptor 9 stimulation, and these mice do develop severe MAS features. This is also true in the reverse experiment. IL-6 binding protein knockout mice have free IL-18 because they lack IL-18 binding protein, the natural inhibitor. They're fine unless they get triggered, again, toll-like receptor 9 stimulation in this paper, and they do develop severe MAS features. So the data in mice are actually consistent with what we have observed. We and others, several people have observed in patients with autoinflammatory disease associated with high level of interleukin 18. Patients with systemic JIA, CDC42 associated, and MC4 associated disease, or CIDE, have very high level, chronically elevated level of interleukin 18, but they do not have MAS all the time. There is the need for a trigger, and this is very consistent with the role of IL-18 as a co-stimulator or cofactor for triggering immune cells, particularly the production of interferon gamma. IL-18 binding protein has been used in two cases. This is a patient with an LRC4-associated disease with recurrent HLH, and once IL-18 binding protein treatment was started, there was a significant decrease in CRP, in ferritin, and the patient did apparently very well. This is again a patient from Alexi, which was reported, I guess, a few weeks ago. Patient with severe, persisting systemic JIA and increased increased recurrent and refractory episode of MAS. And what you can see here, the following beginning of IL-18 binding protein, there were MAS episodes. This is platelet counts, and thrombocytopenia developed. However, ferritin did not increase, and in general, the MAS severity was significantly reduced, and there was an improvement in linear growth and the ability to wean clinically significant low dose of glucocorticoid. So this is where we are now with inhibiting IL-18 binding protein. We have data showing we have an ongoing trial in patients with NRC4 mutation and XIAP deficiency that is actually enrolling, that is presently enrolling patients, and this is the study I alluded to in adult onset Still's disease, which has been concluded, and no other studies, to the best of my knowledge, are being planned. So Alexia alluded to familial HLH and certainly mentioned to you the role of exaggerated production of interferon gamma in driving the macrophage activation and expansion and the cytokine storm that eventually lead the host to death. And this we have learned from familial HLH, where defective cytotoxicity leads to permanent or persistent CD8 activation with long-lasting contact with the antigen-presenting cell and therefore exaggerated production. We have also treated patients with NRC4 disease and the CDC42. There are also two patients who received Emapalumab for MAS in SJIA under compassionate use regimen. Both of them achieved complete response. So I think this data suggests that this treatment is very effective. In summary, I think IL-1 and IL-6 targeting does not offer complete protection from MAS in SGIA. There are case reports of response to IL-1 or IL-6 inhibition in some forms. There is certainly a rationale for inhibiting IL-6 as a cofactor inducing interferon gamma, and the rationale for inhibiting interferon gamma as the major mediator in several disorders in the context of the HLH-MAS spectrum disorder. We have also treated patients with NRC4 disease and the CDC42 patients I alluded to this morning, and they all responded to interferon gamma neutralization with Emapalumab, and Emapalumab has been approved for primary HLH. I want to mention the people who in the lab studied the mice model and the sample for the patient, and Claudia Emanuela were at the clinic together with the Novimmune team who's leading the development of Emapalumab. Thank you very much.
Conclusion: Emapalumab was an efficacious target therapy for patients with primary hemophagocytitis lymphohistiocytosis.
So HLH is Hemophagocytocis Lymphohistiocytosis. I'll call it HLH moving forward. And you get two types of HLH, primary and secondary. And what HLH is it's a hyperimmune, hyperinflammatory syndrome where a patient will present, very often a pediatric patient, will present with a number of signs and symptoms and laboratory abnormalities. And it's very severe, and in many cases these patients die from the disease. So they'll present with high fever, they'll present with a number of enlargements in different organs like the liver and the spleen. Their bloods will be out of whack, they'll have very high levels of pro-inflammatory cytokines, they'll have low levels of platelets and white blood cells and red blood cells, which cause a number of problems. They'll have very high levels of ferritin, which indicates a hyperinflammatory state. And the objective here is to stabilize these patients. So typically they'll come in and they'll get corticosteroids, which is a strong anti-inflammatory, which will stabilize them. But primary HLH, the only curative treatment for primary HLH is hematopoietic stem cell transplant. So the objective here is to stabilize these patients when they come into hospital and then get them to a state of health where they can undergo bone marrow transplant. That's primary HLH. It's genetically driven, defect in the number of genes that predisposes them to this syndrome. There is secondary HLH as well. You can get secondary HLH due to infections, certain cancers, and autoimmune diseases, such as Still's disease. So if I go back to primary HLH, the incidence in the US is about 80 patients per year, so it's a rare disease. But up until about 20 years ago, there really wasn't any treatment for HLH, and many patients died. And then there was the introduction of corticosteroids and the introduction of certain chemotherapeutic agents that have improved the treatment of HLH, but it's still not where it needs to be. It is difficult to diagnose because these patients will come in with a number of different signs and symptoms and laboratory abnormalities, and that could be due to many different diseases. Many different diseases do present like that, with high fevers and organomegaly and blood results that are out of whack. So it can be difficult, and very often the physician and the treating physicians at the institution needs to go through a number of different decision points to arrive at a diagnosis of primary HLH. A true diagnosis of primary HLH is done by genetic testing, but that can take up to 8 weeks to do. So when a patient presents, whether it's primary or secondary, it's not that important in terms of how they're treated when they come into the hospital. So Emapalumab is a monoclonal antibody that is directed against interferon gamma. And interferon gamma is a pro-inflammatory cytokine that is central, one of the central inflammatory cytokines, central to the disease of HLH. And what it does is it actually acts upstream. So what happens in HLH is interferon gamma stimulates macrophages, which in turn stimulates the release of pro-inflammatory cytokines like IL-1, IL-6, TNF-alpha. So by acting upstream and neutralizing interferon gamma, it's going to improve the signs and symptoms and the laboratory parameters of these patients. The phase 3 trial has been concluded, and the data has been analyzed, and this data has been submitted to the FDA, and we're hopeful to get an approved drug in November of this year.